We are excited to kick off our day with the session Meet the Experts, focused on hemoglobinopathies, moderated by Dr. Vasantha Disanayaka and Dr. Yapa Udayakumara. Please join me in giving a warm welcome to them.
Good morning, everyone. So today our first session is going to start. Our first speaker is Professor Anuja Premawardhena. He is a consultant and professor of internal medicine and senior professor of medicine in University of California. And he has special interest and many research done on hemoglobinopathy since 2002. I invite him to deliver his lecture. Over to you, Hamid.
Thank you, Asantha. Good morning, and thank you so much for giving this opportunity. Not the sexiest topic for medicine trainees. Hardly anybody would be here unless they are forced to. Let's start with two cases. The first one is a 28-year-old male who has beta thalassemia major, who presents with shortness of breath. And this shortness of breath is of quite significant intensity, and this patient has significant bilateral ankle edema. The symptoms had started over the last 2 weeks and have been progressive. The patient has orthopnea and paroxysmal nocturnal dyspnea, and this is the first time these symptoms had occurred in him. This patient, as thalassemia state or thalassemia major, was diagnosed at the age of 4 months and has been on regular blood transfusion since. So at the time of this event, he had had over 250 units transfused. So he's very heavily transfused, like he should be. His mean pre-transfusion hemoglobin is 8.8 grams per deciliter. The target should be 9, but he's almost there. It's not splenectomized. Chelation had started at the age of 5 years, not 1, but 5 years. He's on 2 chelators, a combination of desferrioxamine and deferoxerox for the last 2 years. Until then, he had been on a single chelator, deferoxerox. His last serum ferritin has been 6,000 nanograms per milliliter, very, very high. The ideal should be less than 1,000. The one value before that had been 6,800. The highest ever ferritin had been 8,000. He had a history of very bad compliance to chelation therapy. He underwent the T2 star MRI, a technique which we use to identify cardiac iron overload, which identified that he is in the red zone, danger zone for iron overload in the heart. 2D echo identified predictably that he had very low ejection fraction with severe global hyperkinesia. The T2 star of the liver, MRI special technique to identify liver iron overload, showed the same picture. He was in the red zone. We did another technique as part of a research to see the liver iron, to quantify the liver iron overload using a technique called R2, which is called FerriScan, which identified his liver iron quantity to be 43 milligrams per gram of liver iron. Ideally, it should be less than 3. So he's severely iron overloaded in the liver as well as in the heart. Patient 2 is very different. A 35-year-old woman with E-beta thalassemia who also presents with shortness of breath. She has only been transfused 15 times in her life, and the last transfusion was 2 years ago. She's anemic though, because her mean hemoglobin is 6 grams per deciliter. This is a picture which shows significant facial deformities. Her serum ferritin is much lower than the previous patient, 900 nanograms per milliliter. Highest ever ferritin is 1100. She's only on quite a low dose of chelator, 20 milligrams per, that's the lowest dose we give. And the echocardiogram shows normal left ventricular ejection fraction, however, shows moderate pulmonary hypertension. We did the cardiac and the liver T2 star MRI, which shows her heart iron loading to be in the green zone, safe zone. But paradoxically, liver seems to be quite heavily iron overloaded. She's not in the red zone, but in the orange zone. She underwent right heart catheterization, which confirmed the pulmonary hypertension. Right atrial, right ventricular, mean pulmonary arterial pressure were elevated, confirming what was found in the echocardiogram. Before we analyze these two patients, just a refresher on thalassemia and hemoglobinopathies for the uninitiated. Hemoglobin disorders are quite common in the world. In fact, 7% of the world's population have a hemoglobin disorder. And in fact, it's the commonest monogenic disease to affect the human race. And its importance is that it causes a hemolytic anemia. The families who are affected by that, it's a child with thalassemia major, it comes as a surprise because the carriers, the parents, are asymptomatic. Hemoglobin molecule has two components, heme and globin. It is the globin part that we are interested in here today. Globin has alpha chains and beta chains. So there are two disorders which affect these so-called globin disorders. Reduction of production of the globin chains are called thalassemia. So there are two types of thalassemia. If alpha chains are reduced in production, you call alpha thalassemia. Beta chains are reduced in production, you call it beta thalassemia. So in thalassemics, there's reduced production of these hemoglobins, but they have no abnormal hemoglobins. On the other hand, these same globins can be mutated or deformed, causing structural variants, causing very commonly known disorders like sickle cell, and in Sri Lanka, a common condition called hemoglobin E. So there are thalassemias and structural variants. If one parent has a thalassemia and the other parent has a structural variant, the progeny can have a compound heterozygous state like E beta thalassemia. So you get E beta thalassemia if your parent, one parent has beta thalassemia trait and the other parent has E trait. Now, classification of thalassemias is again an area which you have to have a very clear mind. The most severe form of thalassemia is called thalassemia major. The definition, these are man-made definitions. What is meant by thalassemia major or beta thalassemia major, for example, is a condition where the patient is dependent on blood transfusions for survival. So essentially, you are defining a disease which is exceptionally severe. So it's very unlikely you can have thalassemia major and not be diagnosed before 18 months of life. So thalassemia major is diagnosed definitely before your second birthday. The other extreme is thalassemia trait, which is quintessentially asymptomatic. So in between these two extremes is thalassemia intermedia. The most notable thing about thalassemia intermedia is the amazing phenotypic variability. Individuals with thalassemia intermedia could be very mild to very severe. So that's a very variable condition. There's a new classification for thalassemia which categorizes individuals to TDT and NTDT. TDT stands for transfusion dependent thalassemia. NTDT stands for non-transfusion dependent thalassemia. In this classification, the genotype doesn't matter. All you are describing is how much of blood is needed for a particular patient for a particular year. If you need more than 6 transfusions per year, you call it TDT. Less than 6 units per year, you call it NTDT. So these two classifications are used independently or together to describe patients. So thalassemia major, to say somebody is thalassemia major, both parents have to be beta thalassemia traits. And as I mentioned before, because it's so severe, patients must present very, very early in life, usually before the 18 months of life. For physicians who manage them, pediatricians who manage them, it's a very easy disease to manage. Not for the patient, but for the doctors. Because there's a guideline set up by the Thalassemia International Foundation, and that there are just 2 values to fulfill. The pre-transfusion hemoglobin must be kept always above 9. You should never let the hemoglobin drop below 9, and you should always keep the ferritin below 1000. And this is an easy target for the doctor to remember, but very difficult to fulfill. So depending on how you fulfill these targets, the outcomes of patients vary. As is seen in these 2 Kaplan-Meier survival curves from 2 different countries. One on your left is from the survival curve of beta thalassemia major patients in Italy. One on your right is the survival curve of thalassemia patients in India, from southern India. What this essentially shows, the Italian patients hardly ever die. Even at the age of 50, survival is almost 85%. Hardly any patients with beta thalassemia are dead even when they are 50. So life expectancy is near normal. Whereas Indian patients, southern Indian patients who have better survival than northern Indian patients, median survival is less than 20 years. So it's not the disease, it's the way you manage it. How do they die? If you don't transfuse them, of course, they die of severe anemia, which is not seen except in South Asia, in Southeastern Asia. Most of the patients who are managed but managed inadequately die from iron overload. In Sri Lanka, the commonest cause of death in thalassemia major is not due to iron overload, but due to infections. Non-transfusion dependent thalassemia is a completely different kettle of fish. These patients are managed with infrequent transfusions, less transfusions, intermittent transfusions, or sometimes with no transfusions. That essentially means these patients live with moderate or severe anemia. So the mean hemoglobin of this population of NTDT patients, for example, E-beta thalassemia patients in Sri Lanka, is about 6 to 6.5 grams per deciliter. And between the group of patients, they have an enormously variable ability to adapt to anemia. Some patients adapt to anemia very, very well, others struggle. So depending on the ability to adapt to anemia, different complications are seen related to anemia. Complications like facial deformities are hardly ever seen in thalassemia major patients who are very well transfused, but they are very common in NTDT patients. Splenomegaly leading to splenectomy should never be seen in thalassemia major patients who are very well transfused, but they are common in NTDT patients. Leg ulcers should never occur in thalassemia major patients who are very well transfused, but they are common in NTDT patients like E-beta thalassemia patients. The MRI you can see is from one of our patients who we were happily managing for migraine, and then when we did an MRI, we were surprised with this extramedullary hematopoietic mass. These are never seen in thalassemia major patients. but not uncommon in NTDT patients like E-beta thalassemia patients. Iron overload in untransfused or poorly transfused patients occur through gastrointestinal absorption. They behave just like hereditary hemochromatosis patients, and that iron is deposited in hepatocytes, not in the Kupffer cells. So liver cell injury is very common in NTDT patients like ETHAL patients. So cirrhosis of the liver and hepatocellular carcinoma is far more common in ETHAL patients than in thalassemia major patients. The other complication as a result of this is that iron overload as measured by ferritin underestimates the iron overload in NTDT patient. Why so? Ferritin is a measure of iron in storage. Iron is stored in macrophages or Kupffer cells. But in NTDT patients, iron is stored in hepatocytes, not in Kupffer cells. Because iron gets into not macrophages, but into hepatocytes. So if you measure ferritin levels are low. But if you measure iron in the liver, like we did with the T2 star or with the FerriScan, their iron in the liver will be very high. The other complication in NTDT patients is that they don't get a lot of myocardial iron overload. The biggest cardiac injury they get is pulmonary hypertension. With all these complications, you might think that NTDT is a killer. It's actually not. Though they have a lot of complications related to anemia, their survival is actually quite good. So these are again two survival curves of NTDT patients from different parts of the world. In your left is survival of NTDT patients in the Middle Eastern countries, Middle Eastern Mediterranean countries, which shows very good survival for NTDT patients. The other survival curve is from our unit in Ragama, just compiled, which shows the survival of 3 different disorders. In red is thalassemia major. In yellow is E-beta thal. In blue is a group called classic thalassemia intermediate. And as you can see, thalassemia major patients seem to crash and burn. But their median survival is about 40, better than the Indians, but nothing like in Italy. But the ETHALs and the intermediate patients, median survival is about 70 years or more. They are doing much, much better. So coming back to the two groups, management of thalassemia major, the things to remember, the disease is uniformly severe, but management is easier because guidelines are there. And if they do die, it is due to iron overload. In Sri Lanka, it's due to infections. NTDT group, example E-beta thal, management is not straightforward because patients have variable severity, and the variable severity is essentially due to the variability of adaptation to anemia. There's absolutely no doubt that we should raise their hemoglobin. They're living with anemia, we should raise their hemoglobin, but unfortunately, the only way we have to raise their hemoglobin is blood transfusion. But blood for them is poison. We don't have any other alternative, a safe alternative to raise their hemoglobin. We are looking for better alternatives to raise hemoglobin, but transfusion is not a good option for management of E-beta thalassemia and NTDT patients. But because we don't transfuse them, and they really don't need blood transfusion for survival, iron overload again is not commonly seen. So you see this paradox. So coming back to these two patients we started this case with, the first lad with thalassemia major who presented with shortness of breath and ankle edema, he's a thal major who had severe iron overload deposited in the heart. So straightforward case of myocardial iron toxicity. Patient number 2, E beta thal, presented with heart failure for sure, but very limited transfusions, but there was no myocardial iron overload. And this lady had pulmonary hypertension. Now, pulmonary hypertension is quite common in NTDT patients. It is about, on average, 2% of the population, which is 10,000 times more common than in the general population. So, the general recommendation is if you use 2D echo, which we do, if the TR jet velocity is more than 3 meters per second, then for confirmation, you should go for right heart catheterization. Causes of pulmonary hypertension are thought to be multifactorial. We know that certain groups of patients with thalassemia, NTDT patients, the older patients, splenectomized patients, patients with iron overload have a higher risk of developing pulmonary hypertension. But what exactly causes pulmonary hypertension is not clearly identified as yet. So, to sum things up, hemoglobinopathies are very heterogeneous. The genotypes, phenotypes, and complications in these groups are very variable. So, management of this would require an understanding about the specific disease, genotype, as well as the phenotype. Thank you.
Thank you very much for the very informative and illustrative lecture for Premawardhena. I think we have ample of time to ask the question. If you have any questions, you can ask. Yes, Dr. Prasad Jayasekara.
Thank you very much, Professor Anuja, for the excellent lecture. Now, we see a lot of patients, non-transfusion dependent thalassemics, who've been labeled as thal minor. In the course of their illness or with aging, their hemoglobin drops and they are becoming transfusion, sort of not dependent, but their transfusion requirement increases. So is there a sort of a progression of their disease or phenotypic change with age?
Beta thal trait, if they're truly beta thal trait, they will not actually become transfusion dependent. But what can happen is if it is only purely beta thalassemia trait, but if they develop, let's say, CKD, well, then they will develop, you will have to transfuse because of the issues. Say your hemoglobin at the beginning is 9.5. They will inherit all the inherent issues of CKD. So then it is not actually because of the thalassemia, but let's say you develop rheumatoid arthritis, then you have the added problem of anemia of chronic disease. So that you have to take into account. But pure beta thal traits should not have that issue. The only addition to that comment is the category called beta thalassemia intermedia. These can be thalassemia intermedias, which, thal traits masquerading as intermedias. So, how you differentiate is if a thal trait has splenomegaly, pure thal traits can never have splenomegaly. So, if your patient is a thal trait and the hemoglobin is anything less than 8.5, you should always look for an second cause. And if there is splenomegaly, look for another cause. So, thal trait by itself will never give clinically palpable spleen. So, usually if it is, then it is either thalassemia intermedia or another cause.
Thank you.
We have another time.
I have similar question, Professor Anuja. That we day-to-day practice, we see mainly elderly patients. We come across many patients with elderly population with low hemoglobin. When investigate, at the end we find thalassemia trait. Most of some of these patients, but they are not transfusion dependent. Hemoglobin 8, 9, like something like that. Do you have any explanation for that? Or they don't have any other chronic diseases as such? Or is how is their prognosis and progress, sort of?
You mean a thaltrate who gets older?
Elderly, diagnosed in the elderly population, they are quite well in the young age, and once they become 70s or 80s, they become anemic. Normally, we give vitamins and things like that. But when we investigate for anemia, we find that they have thalassemia trait. Mainly, I found a lot of patients in Kurunagal area. I just want to have an explanation for that.
So again, the same thing goes. I suppose they might be just thaltrates who are picked up when they are older. But unless you have a second disease, I don't think you need to worry. But again, you should always take into account whether there are additional factors which come into play with aging. Aging by itself does not cause anemia. So if your older patient, geriatric patient, has a lower hemoglobin than due to the beta thalassemia trait, you should always look for a second cause. So that's,
we give iron for a long time, but hemoglobin is same. That's what I just.
So all that would say is that it's not due to iron deficiency. So it's
Okay, we have another question, yes, sir.
Good morning, sir. This is medical registrar from NHSL.
fancy.
Okay, because of light, yeah.
So there is a recent development of a drug called luspatercept. It's transformation growth factor beta, and this for beta thalassemia, where we can use it in order to reduce the blood transfusion. Any principles as postgraduate trainees that we have to know regarding that, like when you do start, how can you do? I know it's not available in the Sri Lankan context, but regarding some few principles of using and when to use. Thank you.
Are you a medical trainee?
Medical registrar, sir. Yeah.
Amazing. Okay. Good. I'm surprised you knew that. Okay. So this drug is luspatercept. It's a drug that, so this is the magic bullet that people are looking for. So what I was trying to tell is that for thalassemia major, there's no question you have to transfuse, because if you don't transfuse, you die. For NTDT patients, you need to raise hemoglobin, but blood is not the answer. You need something other than that. So in the pursuit of looking for that, one of the things they found was this TGF-beta ligand trapper, which is called luspatercept. And it's now commercially used. Like it's only problem with that is the cheapest product which is available in Southeast Asia is $2,000 per injection. It raises hemoglobin by about 1 gram, but you have to inject every 3 weeks. It's used by thalassemia patients and in myelodysplastic syndrome. So it is useful, but continuous usage is recommended. It's standard therapy for NTDT now. As well as for TDT, it reduces the transfusion requirement. But it's phenomenally expensive. Thank you for asking that question. Good.
Okay, thank you very much. Very informative lecture. Once again, Premawardhena. May I ask my co-chair, founder position, Vasantha Disanayake, to hand over the token of appreciation?